Our next speaker is Dr. Carol Tosone. She is a professor at NYU School of Social Work. She's a recipient of numerous awards, including NYU Distinguished Teaching Award. She's the editor-in-chief of the Clinical Social Worker Journal, and she's the distinguished scholar in social work in the National Academy of Practice. She has edited many books, authors of many articles, and she has studied Manhattan clinicians post 9/11, New Orleans clinicians post Hurricane Katrina, and recently completed a study on the long-term impact of the trouble on clinicians living and working in North Island. And currently, she's conducting a study on COVID quality of professional practice. Her topic will be shared trauma, shared resilience, and COVID-19. Thank you so much. Welcome, Dr. Tosone.
Thank you. I'm delighted to be here. It's a tremendous honor to speak with you. I have a very dear family member on dialysis, so I just know from a familial perspective, and I'm just so impressed with the work everybody does. So it really is very meaningful for me to be able to speak with you. I'm going to be talking a little bit about my research and also the research that I have going on in process around COVID-19. And I hope some of this will resonate for you. It's been a study around I've studied social workers, but I really think that this information can be extrapolated and really applied to all healthcare professionals. I have no disclosures, and basically I want you to be, hopefully from this you will understand the impact on healthcare providers. Now, when we talk about trauma, you notice we talk about anything you're experiencing, witnessing, or hearing about traumatic events. So that takes into account healthcare and mental health providers. And we know certainly military combat, sexual and physical abuse, domestic violence, intimate partner violence, all of these things constitute trauma. We know immigration trauma, natural disasters, racial trauma, man-made disasters. But most importantly, we have to look at subjectively what our perception is that might constitute trauma. So would you find this symbol of Batman, would you find this traumatic? Ask yourself that. Now, personally, it doesn't, I'm certainly not triggered by that in any way. But if you were in the movie theater in Aurora, Colorado, when someone came in dressed as the Joker and locked all the doors, you would find this tremendously traumatic and tremendously triggering. Or how about this? Depending on your political views, some people find this particularly traumatizing. If you're not a Trump supporter, certainly some people find the rebel flag, particularly racially charged, or basic adherents, proponents of Trumpism, they find that very triggering. Or this as well, where you see the swastika associated with the name of Trump. So for some people, what's going on currently politically, particularly it's been linked to the anti-vaxxer movement, finds this particularly charged during COVID-19. Is this triggering? Okay, this is something, this is a crowded stadium in New Zealand several months ago. Now, living in New York and everybody being very careful and mindful of being 6 feet apart for a long period of time, simply looking at this picture, and certainly in California as well, an image such as this might be triggering, be associated with trauma or the fear of contracting COVID. So we have to be mindful of what in fact can trigger, maybe not ourselves, but people that we work with or the patients we work with as well. Now, importantly, I just want to say a little bit about trauma and how traumatic memories persist. If I ask you, where were you when 9/11 happened? Do you have a memory of who you were with, or where you were, what you were wearing, where you were? You probably have a very vivid memory pertaining to 9/11 or the Challenger disaster or other things that are collective traumas. And what we know from the research is that traumatic memories are processed very differently than memories of everyday events. So if I say, where were you on September 5th of 2019, unless you're a creature of habit, you might know where you were, but you likely would not, right? But if I say, where were you on September 11th, 2001, when you heard about the 9/11 disasters in New York and Washington, D.C., I'll bet you would have a memory. And that's because these memories, they're dissociated from consciousness and they're stored as sensory perceptions. So when we think about trauma, it isn't so much declarative, verbiage. What it is trauma is processed through the senses, through what we see, what we hear, what we smell, what we feel on our bodies, the sensations that we feel on our bodies. So they're coded differently than declarative memories, or what we call semantic or symbolic processing. And what it is also, we have a fight, flight, freeze response. So when something traumatic is happening, oftentimes people flee. Oftentimes people are just frozen, like what we call the deer in the headlight response. And these memories are dissociated from linguistic expression. So when people talk about trauma, they often say it's difficult to put into words what I feel, what I've experienced. So again, it's sight, smells, sounds, somatic sensations, not necessarily symbolic level narratives. And what we know as effective for the treatment of trauma, we talk about left and right brain functioning. So left brain is analytic thought, mathematics, science, logic, language. It's all what we oftentimes refer to as higher order thinking. However, trauma is processed in the right brain. That's where you have a more reptilian response to trauma. That is a kind of, when a traumatic event occurs, a lot of the processing with the left brain functions, basically, that is minimized, and then the amygdala gets stimulated. What happens is that part of the brain that's processing the emotions gets activated during trauma. And what we know, the treatments that are most successful for the treatment of trauma actually are those that access the right brain and help to really bridge left and right brain functioning. So if you're involved in things like art therapy, drama therapy, music therapy, yoga, all of these things we know are tremendously useful for processing trauma. And that's also because if you think about it, if I put on a song from when you were 15, right? You haven't heard it in many years. I'll bet you I put it on and I'll bet you can sing along. But if I asked you something you read in the newspaper, I doubt you could give it to me verbatim. But what it is, because these things are processed where creativity occurs, where art and music occur, that gets processed in a way that it gets remembered. So it's emotionally where trauma gets processed, but it is also where the creativity and the therapeutic value of contending with trauma takes place. So importantly, I bring this up because when we talk about the importance of self-care, those are right brain activities, especially things like yoga and mindfulness. And the goal in trauma treatment is basically, a lot of times people have hyperarousal, and there's where you see intrusive imagery that comes in, unwanted nightmares, basically a strong emotional reactivity, or you have hypoarousal. And this is where you see people who often feel that they're burned out describe this. Their affect's very flat. They feel apathy. They don't feel things for people. They don't feel things for their patients. And there's a numbing that occurs. So the goal in treatment is also to get somebody within this window of tolerance, as we call it, the optimal arousal zone. And coming from a healthcare background, I knew this when I worked with terminally ill cancer patients. I found myself after a while, it was like, oh, do I have to go in this patient's room? They're going to die soon anyway. Do I really need to go in? I found myself distancing from the patients and from their families. and finding a rationale for not wanting to engage. That's how I knew for sure I was burning out. Another important thing about trauma is adverse childhood experiences. Those of you who are familiar with that, those who score higher on the ACEs tend to have higher degrees of trauma. And importantly, trauma is intergenerational. That is oftentimes what you see is trauma occurs, somebody who is abused as a child and they have problems in school, conduct disorder, etc., PTSD. As an adolescent, they move to substance abuse to deal with it, maybe dropping out of school, become re-victimized, and you see a lot of, certainly a lot of young girls that were sexually abused. You find them gravitating towards partners where that occurs again. And then as adults, you also find the substance abuse occurs, higher degrees of poverty, depression, intimate partner violence. And then what you find is that leads again to a cycle of abuse. So there is an intergenerational transmission of trauma, and especially we find that for many of our clients. Now, COVID-19, in my studies, as has been referenced, I've worked with a number of groups, but this is really the first time where we're talking about a global disaster, a global pandemic. And just as of a couple days ago, you can see really less than 2 weeks ago, we're not far away from 5 million total deaths. It's astronomical, the number of people who have died or have been impacted by COVID, not to mention the impact with families, friends, etc. And I'm sure all of us, if you haven't contracted it yourself, certainly know of someone who has, and I'd be shocked if there's no one in the audience who doesn't know someone who has been impacted. So this is really a global collective disaster, if you will. And we know also what it's really brought to mind is the intersection with the racism pandemic. We can see that those minorities who are impacted much more than those who are white. You can see Native Americans, Hispanics, Blacks, Asians, that they have a much greater amount of hospitalization, deaths, etc. Same thing by age when we look at it. Older people are really much more likely to be hospitalized and also to die from it. So we know that there are people more at risk. So what the COVID pandemic has done, it has really thrown light on the intersection of the racism pandemic, communities that are more disadvantaged, communities that are really more skeptical of vaccines and other information that's coming from our federal healthcare providers. So it's really revealed a lot of things that many of us may not have known, not to mention the xenophobia that is really going on as well, where we've seen a lot of violence against Asians and Asian Americans because of this. Another thing it's thrown light on is really the tremendous need with people losing jobs. Of course, we now have an opposite problem now, if you will, but a lot of people in need, and we can see what's happened. It has increased poverty for African American and Latinx children during the pandemic, as well as for female-headed households. So when we talk about these statistics, I want you to understand it. I want you to understand trauma as poverty, poverty as trauma as well. In other words, there really is a reciprocal relationship, because trauma, people who experience poverty, who have food insecurity, that can be a very traumatizing experience as well. Now, what we know about COVID in relation to kidney complications, people who are very ill with COVID often experience kidney problems. Kidney failures led to shortages of machines, supplies required for emergency dialysis. Sicker the COVID patients were, the more likely they were to experiencing lingering kidney damage. And up to 6 months after infections, they're 35% more likely than non-COVID patients to have substantial declines in kidney function. And so we know that there's been tremendous damage that can occur, and the risk is higher for those who are older, had diabetes, lived in community with high coronavirus prevalence, and received dialysis at clinics serving more patients. That is, those in clinics rather than necessarily at home. That there was much more reports of COVID. And that's particularly for Black and other at-risk minority racial groups or socially, economically disadvantaged populations that are greater risk for kidney complications and those already on dialysis. So very important to keep in mind that you're working with a very high-risk population. And when we know about the psychological impact of everything, we know about the mistrust, we know about the concerns around conspiracy theories, we know about quarantine, but importantly, social supports from family, friends, colleagues can counteract the negative psychological consequences from the ravages of COVID. And this is important because social support, and what I found in my research from 9/11, Katrina, as well as the long-term impact of the troubles in Northern Ireland, and what we are finding from our initial look at the data from COVID is that people who felt that they were working in institutions that served as holding environments, and by that I mean they felt that they were working for institutions that were supportive, that believed in self-care, that were helpful, that they were faring better than those who felt that the agencies that they worked for did not care for them. And I'm going to share with you some preliminary information that we've gotten so far from COVID, but it looks like it's kind of consistent with what we're finding with the other studies that I've done. And that is that agencies, organizational context can make all the difference in how someone fares. This was from early on in New York. So this is what we've resorted to in New York City. Help us, we need personal protective equipment. And you can see this is a doctor taking care of somebody and how they feel about it. And we talk about heroes of the pandemic. And one of the respondents said, I feel very weird when people call us heroes. I mean, we did go to work every day and legitimately feared for my life of those days due to the pandemic. Every time I stepped into a room with a COVID patient or even walked through the ER, the thought went through my head, what if I get it? And now that the pandemic is, quote, over, watching the world turn back is on a bigger challenge because it's like all the work we did during the pandemic's forgotten. Healthcare providers literally have not taken a beat to pause, reflect, and process our experiences. We're immediately back to being busy all the time, people being disrespectful, entitled, and I'm noticing tempers of many of my colleagues are a lot shorter right now. So there hasn't been time for anyone to process it, and it's still going on. Now, I think this is very relevant. Concepts such as burnout and compassion fatigue in particular. I want to focus on these for you because this is what we see, especially with healthcare providers. The idea that oftentimes compassion fatigue is a cumulative fatigue that sets in, and it comes from the cost of caring. That's oftentimes how compassion fatigue is defined. It's a cumulative effect saying that we care so much, we get burned out. It encompasses burnout. And burnout, we know when we see people very depressed, feeling more numb, more isolated. And there are a number of other concepts that have come about because of it, but I won't spend our time on these. They're more related to mental health providers. But shared trauma, and this is where my research is on, is I think important because I started it with my research on 9/11 when I was sitting with the patient and the plane flew over the building. And I wondered if my experience was anything like other providers. I watched the towers burn. I was with my client. I had many clients who, some of whom worked in the towers. It was tremendously emotional for me. I cried with patients. I said, wow, did anyone have this experience? And what I found is that it's a comprehensive experience. It impacts the way we think cognitively, affectively, the way we feel, behaviorally, the way we act, and spiritually. And people are transformed as a result of this experience. And another thing, what it does is it underscores the symmetry of a therapeutic relationship, and not just in mental health, but in healthcare as well. In other words, we're going through it the same time as the patients we work with. And it's an opportunity for us to better understand ourselves and to grow from the experience. So what happens is you've got a shared collective trauma. It impacts the provider, it impacts the client, and you have new boundaries that result from this experience. And what we know is the people at highest risk for compassion fatigue are younger, new people coming to the field that are bright-eyed, bushy-tailed, enthusiastic. If they've worked in a lot of traumatological environments, if they've been exposed to trauma in the workplace, if they have a past history of trauma personally, if they have a history of depression or anxiety, there's a lot of comorbidity, or for those in mental health who did a lot of counseling, post-disaster counseling efforts. So these people are at higher risk, particularly neophytes working in healthcare and mental health. Now, but that's kind of the negative of it. The positive of it is you can have a lot of positive changes in regard to post-traumatic growth. So you can see changes in one's sense of self and relationships, the way one views the world, how one views the future. A lot of people get politically motivated. This is what I found in my Katrina and 9/11 results. And then something a colleague and I coined the expression professional post-traumatic growth. A lot of people were making professional changes that benefited their life. Now, this is a word cloud so far. We had over 4,000 respondents to the survey. It's the COVID-19 Quality Professional Practice Survey. And we had many people. These are just the responses from the open-ended questions. We're in the process of doing the quantitative data analysis, but right now you can see the biggest concern people had was family. They all talked about their concern. They concerned about were they going to bring the virus home to their family unwittingly. Their concern was how family was doing. And people had issues going on. We don't just have a collective trauma and everybody had an ideal life before. People had family members with health issues, with mental health issues. So the concern was how would their work impact what was happening with the family? Their family needed them first. How would they take care of kids who had to go to school? So all of these things were big. And the biggest affect people reported on was isolation. People felt a lot of isolation. They felt stressed out. And we found, I looked at social workers, many of them wanted to leave. If they weren't leaving the profession, many of them were leaving hospital settings in particular and wanting to go into private practice because they felt overwhelmed by their hospital experience. So there was a lot of stress, a lot of anxiety, a lot of mental health concerns, and a number of people who had COVID. And the big thing, the big takeaway was we need more self-care. One of the things they learned is we need self-care. And unfortunately, out of 4,000 respondents, I don't think I can find any of the open-ended questions where people were talking about how they felt supported by their agencies. They were talking about not getting paid time off. They were talking about having to use their sick time for COVID when they contracted it. They were talking about not having sufficient trauma training. They were talking about needing more disaster management training. They were talking about not having enough training in technology. So there was a real sense of we need more support from the organizations that we work in. And also, you can't talk about this devoid of the issues around politics. A number of people, and this was a national survey, and I could tell you from some of the responses what parts of the country they came from, just from their responses. People were concerned, again, like a lot of Zoom fatigue we talked about. Yes, self-care kept coming up again and again, but politics was very big. The idea that it made it much harder. Here we're trying to help people. But we have to deal with this in relation to the politics that are going on that is making the external environment much, much more difficult. And here are just some things, some comments that maybe may resonate for you. Somebody who had COVID said, I initially experienced difficulty when it came to my experience with COVID and that of my clients. Never before my clinical experience could identify with what every single client was going through because of COVID. Someone else said, I shared more of myself personally with patients as they were concerned about my story as well. This is shared trauma. It says we are all in the same boat together. So what it did is it created more of an intimacy with their patients. Someone said experiencing national trauma simultaneously as clients, navigating what it means, suffering from worsening mental health while having to assist others with theirs. And somebody else talked about, who was on Zoom, saying, clients see my house, they hear my dogs bark, they know when packages are being delivered. There's a shared experience that we've gone through this together. And there were times when my clients were the only people outside of my family I saw. Some of my clients, I was the only person they saw. This creates a very different dynamic, and I continue to wonder how this has and will impact my working relationships. So again, it creates a greater intimacy and a leveling of the experience. Now, with compassion fatigue and secondary trauma, just to give you a taste, and some of the reports of the agency settings were absolutely scathing. Here's one: my organization's been plummeting. Every department's extremely short-staffed. My supervisor's leaving. The direct service workers are already gone. Work's extremely stressful, not because of the trauma the clients deal with, but because of the organization. We didn't get our annual raises. We haven't had anyone work on reception. There's no support. Long-term employees are leaving left and right. Somebody's saying I'm harder, more cynical, angrier. Multiple traumatic circumstances compounded in my life, one after the other, medically, emotionally, spiritually, relationally, cognitively. And given the fact that I was never given time off through the entirety of the pandemic, my paid time off was used while I was on an unplanned medical leave. I've been chronically exhausted and bitter. Somebody else says, I've been burnt out and lost my passion for this field, and I'm preparing to pursue a different career as a photographer. I no longer want to be surrounded by miserable people each day, and helping is no longer important to me as a human. I feel that I've paid my dues. And it's a sad statement that we've come to that. And for people who have contracted it, they've had long haul symptoms, and they're saying how difficult it is to work with people who deny COVID or support politicians who have no medical knowledge, promoting mis or disinformation. And then here's somebody who's saying, I was sick all this time, and the only time I took off was, when I was very ill. And I wish I could even have a week off, but all my earned time went to COVID, and I can never catch up. Obviously, this is a recipe for burnout, and I try to provide excellent clinical care despite it. Documentation demands pile up, and I feel a perpetual failure. Okay, and another thing we found is that within families, people were finding they were fighting with their husband. Here is somebody fighting with her husband of 20 years who supports Trump. She had to covertly have her 15-year-old son vaccinated. and doesn't know if she won't end up divorced. And somebody else talking about the political and economic climate, anxiety about violence, protesting. And then they're saying, well, it's changed my values personally and professionally. And the concern around the dual pandemics of racism and the divides between the have and have nots. So what you find is it's brought about so much more. But there is a positive, and we see a lot of post-traumatic growth. So you need to think for yourself, what is the lessons that you're taking away from this? So people feel more present. They feel, that they've got better boundaries they're setting up for themselves, more compartmentalization, not confusing clients' issues with their own, better relationships with their family. And they're giving themselves time to do things they didn't do before. Learned new hobbies during the pandemic, spending more time with loved ones, and got a better work-life balance. And professionally, we saw that a lot of people, again, shifting from agency to private practice work. And again, this is with mental health. But you also see additional concerns. These are existential. People are asking larger questions. Makes me think, what's my belief about the afterlife? Life is short. Pandemics life affirming and reinforce the values and committed lifestyle I made pre-pandemic. So what we're finding is it has people think about their life again. And it's not surprising that we see that the whole issue that a lot of people are leaving their jobs, they're retiring early, and this is really across all job sectors. And that's because people are rethinking, if life is short, how do I want to spend it? So someone's saying, I'm more confident in my life's mission, more loving towards my family, more grateful of the blessings of my life, how appreciative of the beauty of human life, more wary of politicians, etc. Now, 9/11 occurred. Now, this is what the process we're looking at. What we know is that people who are more insecurely attached are more prone to shared trauma. And shared trauma is the professional's dual response to trauma. That is, they're impacted personally, PTSD, as well as secondary trauma. And we know the more insecurely attached they are, mediated by resiliency, the more likely they are to develop shared trauma. But the important takeaway that I believe is applicable to all health professionals is we found that you can be insecurely attached, you can be burned out, you can have a high degree of trauma, but yet you can also be resilient. You could also love what you do. You could also have strong compassion, satisfaction in what you do. So this is important, that you could be in some ways burned out, but still believe in the importance of what you're doing. And you don't have to be ideally attached. By that, I mean, you don't have to be the paragon of mental health. So importantly, we found this in 9/11 as well as Hurricane Katrina. And that's Hurricane Katrina. And the complicating factor here, and you may know this for your work with dialysis patients, is one thing we found with Hurricane Katrina is many of the clinicians felt very guilty because many of their homes were destroyed, but they were able to leave. And they felt guilty because these are their clients that were in the Superdome and unable to leave. So guilt complicated things. So same thing, you can see a similar pattern here. But you can also see that they reported a lot of guilt. And we have the same thing, they're high in resiliency and compassion satisfaction, and moderate, if you will, on compassion fatigue, as well as PTSD. We've looked at stuff in relation. This is, I've worked with clinicians by the Gaza Strip, in Sderot in southern Israel. I have lectured to clinicians, and I've helped them develop educational material in Afghanistan, and it's absolutely horrible what's happening in that country now. This is a restaurant that actually we celebrated. They did not have social work as a profession. I was involved with the government in establishing it, developing all of the job descriptions, et cetera. We went to celebrate, and not shortly after that, it was bombed. Same thing here. I used to sit in a traffic jam right by this wedding hall, and sure enough, that was bombed. And we know something just happened today, which is horrible. Northern Ireland, we look at the long-term chronic impact of people who are living and working during the Troubles. Those of you unfamiliar with that, it's a sectarian violence between the Protestants and the Catholics, took place over a 30-year period. And again, what we found in all of these instances is people who felt unsupported. We just wrote a paper in the British Journal of Social Work, and the title of it was "Just Get On With It." And that's what the social workers were saying. They were going through their daily bomb threats. They were stepping over mines that hadn't exploded. They were on roads that were known to have bombs on them, but they said, you just get on with it and you do your job. So the heroism that certainly you as well do in your everyday work. And we think about, how has COVID permanently changed things? Certainly, we've all had to get more facile in terms of technology. Older adults also having to get more facile with the use of technology. And we're doing things we didn't even realize we were capable of doing. And to what extent is this permanent for us? To what extent does this occur in an ongoing way? And we see adaptability. We see what's happened with the masks and with people getting used to working online. And we can't ignore the grief that occurs. So as much as we want to get back to where things are, we really can't ignore what is occurring. I want to stop. I have some time, but I really would like to, you're welcome to the PowerPoint. Anybody who wants, you're welcome to have the PowerPoint. All I want to say at this point, I just want to leave you with a little exercise in regard to self-care. We know self-care is super important. Many ways to do it, and it's all the things we know. We know about deep breathing, we know about physical health, we know about better nutrition, we know about exercising, we know about all this stuff, but how many of us actually do what we tell our patients to do? That's the question. And mindfulness, we know, is one really great practice. It's an important form of self-care. If you're not familiar with it, the Calm app is wonderful. 10 minutes a day is a great thing. And we know it decreases burnout and secondary trauma. It helps us from obsessive ruminations. It improves our mood. It does all kinds of wonderful things. There are things, body scans, breathing exercises. But the one I want to leave you with now is really now, just kind of put your hand on your heart. Take a couple deep breaths, all right? Just give yourself 3 or 4 very deep breaths. And every time you breathe in, breathing in is an act of self-love. We can't not love ourselves. Breathe in, we nurture ourselves. And when you do, I want you to say some things. I say some things to yourself. May I hold myself with compassion. May I love and accept myself just as I am. May I remember to treat myself with love and kindness. And may I open to my experience just as it is. And give yourself one gigantic hug. You deserve it. You've earned it. And it's really been a tremendous pleasure for me to speak to you today. And I welcome any questions that you have.
Wow. Dr. Tosone, thank you so much.
Oh, my
This
pleasure.
is such a timely topic. I had so many comments in the chat that so resonate what you just said. We really need to support each other. I was reminded I have 5 minutes for Q&A. I have a question from Dr. Green. Let me put it up. Here we go. So she said, quote, "I so appreciate this topic. Do you have any advice for providers who has first impact by the wildfire, then by the COVID?" I think is one traumatic experience after another. In our areas of Sonoma County, more than 200 physicians and the countless nurses and other caregivers lost our home or were evacuated and traumatized the fear of the fire, then now re-traumatized again from COVID. How can we overcome? How this make us feel?
Okay, one thing, it's absolutely horrific what is happening in California as well as the wildfires elsewhere. It's unbelievable because you've got all of those collective traumas taking place. One thing that we found in the research, which is so true, know thyself. If you're not taking care of yourself, it's very difficult to take care of others. But what we also know is those of us in the helping professions, we're helping ourselves when we help other people. During 9/11, I did a lot of volunteer work, and I have to tell you, it helped me to be busy helping others. It connected me with a sense of efficacy. It made me feel like I was doing something, like my actions had value. They weren't impotent actions. They led to someone else being better. So you need to know yourself. In other words, take care of yourself and others, right? You and your loved ones. And then if it helps you to help others, then do it. If you need to retreat and take care of yourself, you do that. You put that front and center.
Great. Yeah. There's so many comments. Thank you. And they also have so many comments on how to go through, help each other through this trauma. There's comments, they found it very powerful and grateful, many comments. I have a question isn't it time for us as a whole, as a society, to shift our priority towards from more achievement, more publications, more promotions, bringing more money for the organization towards helping each other more, taking care of patient more, that we build up a society that we help each other, not we measure each person not by how much wealth that person produce, yet by how many lives they impact.
Right. That's a wonderful comment. In some ways, it's also an indictment of our society as it stands now. The fact that the one's monetary value in terms of what you're making, somebody is kind of valued as more successful, when in fact the remuneration from what we do is in fact what we do. In other words, the value, it's very much tied with a sense of purpose in our lives. And a lot of people can't say that. And anyone in a helping profession, especially if it feels like a calling to you. I mean, I work in social work and social work education. And I always say to people, if this is not a calling for you, do yourself a favor, get out, because you're going to be dealing with low pay. You're going to be dealing with people who don't fully understand what you do, who don't appreciate what you do, who associate you with the clients you work with and will be devaluing of the clients. So if you don't have an internal locus of control and belief in the importance of what you do, it's going to be a lot harder to stay in the field. So that's why the social supports from our colleagues, like-minded people who also devote their lives to helping others, I think that's an important community. That's where the value comes in, because there's a larger skewed view in society should not impact what we feel about ourselves and the worth of what we do.
Great. I think I would 1 minute, I would go through some of the comments. Dr. Basra said, the isolation is worse when the nuclear family of 3 generations is geographically separated and unable to support other than by Zoom or by phone. Yeah. And our patients are also very isolated.
Right.
Great. Thank you so much.
My pleasure.
It's really timely, and thank you so much for all your work, all your research. Looking forward to learn from you again. I'm looking forward to read your books.
Okay, we have one out. There's actually an edited book out on the topic already that came out, and you're more than welcome. Be glad to send a copy along.
Oh, that would be great.
Okay.
Thank you.
You're welcome. Okay,
Bye-bye.
take care. Bye.